Thank you very much for your kind introduction. I'm very happy to be here to present a meta-analysis from our group on the effects of SGLT2 inhibitors on cardiovascular mortality in our patients. So we know that RAS blockers represent the cornerstone of nephroprotective therapy, but it is known from studies in patients with CKD that these agents do not reduce cardiovascular events or mortality. Over the past few years, an increasing number of clinical trials in various populations at high cardiovascular risk have shown that SGLT2 inhibitors offer several cardio and nephroprotective properties, and they significantly reduced cardiovascular mortality in different subpopulations, including patients with diabetes. You see here the results from the APARENC and CREDENCE trials, as well as in patients with heart failure, either those with reduced ejection fraction or them with preserved ejection fraction. So we have similar results from several trials in patients with CKD, and the aim of the present work was to evaluate the overall effect of SGLT2 inhibitors on cardiovascular mortality and events in patients with CKD at baseline and across different subgroups defined by the kidney function. So we performed a literature search in major databases including PubMed, Web of Science, Scopus, and the Cochrane Library up to 15 November 2022. We included randomized clinical trials assessing the effects of these agents, SGLT2 inhibitors, on the primary outcomes in patients with CKD at baseline or across the different subgroups based on the baseline GFR levels. The primary outcome was cardiovascular mortalities, and the secondary ones included all-cause mortality and major adverse cardiovascular events. Here you can see the study flowchart from a total of about 6,500 records screened, a total of 11 studies with more than 83,000 participants were included in the final meta-analysis. With regards to the primary outcome, which was this cardiovascular mortality, you can see that treatment with an SGLT2 inhibitor reduced by 14% the risk for cardiovascular death compared to placebo, and similar were the findings from the secondary outcomes, with SGLT2 inhibitors reduced by 15% the risk for all-cause mortality and by 30% the risk for major adverse cardiovascular events. What is really important is that these beneficial effects were independent of which agent used, as indicated by this subgroup analysis according to the different SGLT2 type used, with all of agents used, canagliflozin, dapagliflozin, empagliflozin, and sotagliflozin, reduced significantly the cardiovascular mortality without any between-group differences, suggesting the presence of a class and not of a drug effect. Similarly to the previous subgroup analysis, a consistent treatment effect was observed when we stratified the population by the baseline GFR levels into those with GFR above 60 and into those with GFR lower than 60 ml per minute. As you can see, treatment with SGLT2 reduced by almost by 18% and 14% the risk for cardiovascular death. And finally, in sensitivity analysis, including only patients with diabetic kidney disease, the results were similar. SGLT2 reduced significantly by 14% the risk for cardiovascular death in all the studies. So in conclusion, treatment with SGLT2 inhibitors led to significant reductions in the risk for cardiovascular and all-cause mortality in patients with CKD, and these beneficial effects are unaltered also in different high-risk groups, as they are patients with diabetes and those with the progression of CKD and lower GFR levels. And we can say that these findings support the use of these drugs, not only for nephroprotection, but also for protection against cardiovascular disease, cardiovascular events, and death in patients with CKD. Thank you very much.